Good afternoon, ladies and gentlemen. Welcome again to yet another of our COVID seminars from the Royal Society of Medicine. Now then, excuse me, our loyal followers in Australia who previously pointed out the lopsided picture behind me will be pleased to know that it's now gone for reframing. So that has gone, but unfortunately, if you look carefully, you'll notice I now have a lopsided hand, courtesy of a cycle accident, playing havoc with typing and research, but fortunately not with the ability or inability, however you look at it, to present these webinars. Now, fortunately, there's nothing lopsided about our guests today who are firmly on the straight and narrow as we turn our attention to the world of medical journals. Delighted to welcome Howard Bauchner from the editor of JAMA, and Fiona, actually I've written here Fiona Godlee. I'm terribly sorry, Fiona. Fiona Godlee, nothing godless about Fiona, from the BMJ. Now we'll give Howard a minute longer to catch up on his sleep because he's in Chicago whilst I introduce Fiona, who qualified in Cambridge and indeed has lived there ever since, I think. He joined the BMJ in 1990 and hasn't had a proper job since. And indeed became the first female editor of the BMJ in 2004, replacing the great Richard Smith. Now, in an interview, you told recently that your best career move was not getting editor of The Lancet in 1995, where you were picked by a fellow called Richard Horton, who has subsequently disappeared into obscurity. Now it's time to wake up Howard Bauchner, JAMA editor, qualified at Boston University and Berkeley. You are a pediatrician of distinction, and you indeed edited the Archives of Disease and Childhood from 2003, which is a BMJ journal. So indeed, you are being joined by your boss, next to you on the screen. However, you finally cast loose and took over in JAMA 2011, the most widely circulated journal in the world, and you've created the JAMA family of journals. Right, so welcome to both of you. Let me just check you are both there, and indeed you are. The mass wonderful technology's worked yet again. So let me start out, and we've had a question just literally come in from Due Strength, who has to be the same Due Strength who edits the Dutch Journal of Medicine. And so we'll kick off with that because he tells us 10% of his submissions are COVID related now. And he's wondering, A, how is it for you? That's you too. And how are you managing to cope? Just how big has been the increase? So Howard, you now fully awake with us. So would you want to kick off?
Thanks so much, Simon. I just want to start by acknowledging the remarkable leadership that Fee has shown at BMJ. I grew up at Archives of Disease and Childhood under Richard and then Fee, and I think in part I've been fortunate enough to end up at JAMA because of the two of them. And
that was a good slip.
Yeah, that was a slip.
Yeah. Yeah.
I just want to thank both Fee and Richard. They were extraordinary mentors to me. Well, right before we came on, I mentioned the numbers. So between January and June 1, last year, JAMA had 4,000 submissions. This year, we've had 11,000 submissions. And the additional 7,000 are all related to COVID-19. Of the additional 7,000, about 12 to 1,500 have been research letters, about 1,000 have been what we call a piece of my mind, which is a narrative section. And the remaining 4,500 have been either brief reports, viewpoints, or original investigation. And we've limited, obviously, the number of publications. We've published about 175 COVID-related papers, of which about 8 or 10 have been original investigations, about 40 or 50 have been research letters, and the remainder have been either opinion pieces, viewpoints, or pieces of my mind.
So that's a big increase. And you're all presumably, or you're obviously in the office, at least unless your house is different to what I normally recognize. But most of you are working from home?
So JAMA is owned by the AMA, and we went to work from home about 2 or 3 months ago. So the entire editorial and publishing group, which is about 225 people, I would say 95% are working from home. I do a lot of video and audio, so I come in the office every day. And then when I do live streams, there'll be support staff who come in. But everyone's working from home, and Tom Easley, our publisher, is really proud, as am I. We haven't missed a beat. We haven't missed a single publishing date. And that's a tribute to a lot of people's hard work.
Okay. Now, Fiona, I think you are at home, although you've carefully put your branding up, which is.
I know. I felt I had to. You know, we had a bit of a branding. I don't know what the word is. Competition before we came on air, and I was really aware that my branding was a bit less intense than how it is. So I put up a few copies of the BMJ on the wall. So if they fall off, you'll recognise the difference in resource that the BMJ and JAMA has to have.
But you are at home, I think. So you're in Cambridge. And how's that been? Again, have you, as far as I can see, you still seem to be producing?
Yeah, no, it's been great actually. I mean, we've just in response to to give the same answer the question about the volume of stuff that you put to Howie. We've had an enormous increase in volume. It's been quite dramatic across not just the BMJ, but all of our journals, BMJ Open, the 70 plus specialty journals that we publish have all had a flood of submissions. It's an extraordinary time when the whole research and clinical community across the world are focusing on one topic. And that's been, in many ways, also very interesting and challenging for the editorial team, because for the first time we as a group of sort of 50 plus people are all also focusing on the one topic. So our editorial meetings are much more kind of communal and shared in that respect. But yeah, we've seen a huge uplift in submissions, also in an expectation of speed because of the public health emergency, the clinical emergency. So we've done, I mean, I would say an extraordinary job as a team. The team has been fantastic across research, editorials, comment, education, opinion. We've got the opinion section running extremely fast. We can get opinions up in about an hour or 2 hours, having been read and edited. So that's a way of getting really topical comment up. The research, we've really had to raise the bar across, the initial, it's one of those things where you begin taking stuff because it's what comes in around COVID and everyone wants to read about it, and then quite soon wanting to raise the quality bar to really make sure that we are applying the same levels of scrutiny and peer review as we would to any topic, but also trying to do that at speed. So it has been an extraordinary response, I think, from the BMJ's team, and also it sounds like from JAMA's team as well.
Okay, well, I mean, already several people, David Canish and now Jeremy Wright, are asking the obvious variations on the theme of how are you going to continue to or to protect the integrity of research given this push to publish COVID-19 papers and the need for speed. So, I mean, basically, let's start off with the topic, the big retraction, which the New York Times on Saturday, many times has actually returned to this as being as a turning point. And Jerome Cassira, former editor of the New England Journal of Medicine, said about the loss of trust. He said, these are big blunders, problems with trust. It's too easy to lose and too hard to get back. So Howard, do you want to take us through the big retraction? Sure.
So actually, it was interesting. I was interviewed for the New York Times, and then they decided not to take my quotes.
Typical journalists.
So I would say retractions always happen, and JAMA has had retractions, and every time we have a retraction, we do a root cause analysis to understand where was the lesion, and there's many different possibilities. The first thing I would say is that editors can't have it both ways. We can't say that peer reviewers are consultants to us, and then if there's a retraction, blame the peer reviewers. That really puts peer reviewers in a very, very unfair position. And so I would hope, Lancet and New England Journal are trying to understand why these retractions occurred. The same group has submitted numerous papers to JAMA. We've elected not to publish any of them. I would say what's critically important is when issues around fabrication or falsification come to the attention of journal, how quickly do they respond? And in this case, I think both journals responded quickly, but I think both are obligated to go back and look at the record of these manuscripts and try to understand where the mistakes were made. I would say if authors fabricate or falsify data, it is almost impossible initially for journal editors to pick that up. And my last comment, I'm curious what Fee thinks. There is a rush to publication, and it's a huge mistake. And I've written about this. Most clinical papers take years to affect clinical care. So if you've done a clinical trial and it's taken 3 years and then you want to publish in a month, it makes almost no sense to me. And I think more and more authors and investigators and journal editors are beginning to understand that. Now with the pandemic, it's somewhat different, but there's other outlets. Now this flows into preprint servers. I'm mixed about them when we think the studies are really going to have important clinical impact. We've had a number of papers that have been put up on the preprint server, and the form in which they were put up, they were entirely incorrect, and they led to the wrong conclusion. And after peer review, the conclusion entirely changed. So I think preprint servers really serve a purpose, but it depends upon the type of material that's going up. But for example, recovery, wherever it is, there's no reason to rush it. It's already in the public domain. The authors have already released the data, both publicly and then through a preprint server. So there's no reason for a journal to publish it in 3 or 4 days.
Yeah, your recovery, you mean the dexamethasone results?
Correct. Mm-hmm.
Yeah, okay. Fee, what's your view?
Well, I think, the big retraction is obviously a shame. It's a worry. It seems to be likely to be a bit of fabrication, and that's not good. I think it's possible that any journal could have been caught by that. Since Howie has declared, I'll go against type. I mean, don't normally do this, but to say that we too have had a paper from this group, and in our case, we're holding on to it to make some inquiries. Before we're obviously going to reject it, but and thankfully we weren't going to publish it, but we're making some inquiries to try and find out what happened. I think, however, peer review is a very flawed process, in lots of ways. It's a human process. People make mistakes. I agree with Howie that it's the journal's responsibility. We have open peer review, whereby the authors will know who the reviewers are. And in most cases, we publish the peer review comments alongside the research article when published, although in some cases we feel we need to protect the reviewers. And if there are legal issues involved, we don't do that. So that's just an additional, we feel, a kind of piece of transparency that's helpful. I agree with Howie that really with the rush, I think this is sort of what you're saying, the rush to publication, preprints is an answer, although, I know you, Howie, have some concerns. I'm a fan of preprints. We, the BMJ, are partners with Cold Spring Harbor Press and Yale on the MedArchive, which has been an amazing phenomenon, really. I mean, it was launched only just at the end of last year. I mean, it couldn't have been more on point.
Let's come on to preprints in a moment, Fee. Can we just still stick with the retraction?
Yeah.
Mm.
What more?
I mean, the one thing I want to ask, which is one rather odd thing, because normally when you see dodgy stuff or fake stuff, it's usually to promote something. But this one, is this very unusual where it's done the opposite? I mean, it wasn't exactly wrong, was it? The bloody drug doesn't work.
Well, it's often hard really to unpick what is the motivation for people who, I mean, I'm speaking, one has to say I sort of alleged at the moment.
Yes, of course.
I don't know the results of any inquiry that might look into this, but there is a suspicion that there is fabrication of data here. Lots of things point to that. And motivation for these sort of things is very hard. I mean, there's financial motivations, which may be because a database is being built and might have financial underpinnings. There's a sort of, reputational and status motivations that may be behind it, or just some, general desire to be part of the picture and be up there in the media. So, I mean, in both of the cases, the Lancet and the New England Journal papers, these were core drugs that are being discussed, hydroxychloroquine and ACE2 inhibitors. And so these were absolutely topical, and you can see why the journals, and this is a big risk for editors, saw the topics, saw the results, thought, great, this is exactly what we wanted to say. We wanted, in the Lancet case, not only to show that hydroxychloroquine didn't work, but that it was harmful. So this study fits that picture, and hooray, that's a risk with all editors when something confirms your bias, that you don't scrutinize it as firmly as you should. And likewise with the New England Journal, it said the things that people were hoping to hear. So as you say, it wasn't an obvious commercial that it wasn't an obvious, that there are lots of things about this that are unusual, but I think the risks are absolutely there to be seen by everyone about how journals can fall into that trap.
And it's true, isn't it, Howie, that the bigger the impact factor, and your two journals have big impact factors, the more, not less, retractions that you make.
I think around the whether or not we retract papers or don't retract papers, for us, the most important thing is when we put out an original investigation is that the results are valid. We don't really think about whether or not it will influence the impact factor. I would say
I didn't mean that, but it's more but there is a correlation between the two.
Between?
Well, that having a high impact, producing a lot of high impact work, which you clearly do,
right,
does also seem to be associated, maybe you are drawn to like a moth to the flame of a really big, potentially paper.
But we've held up what we thought were our most influential papers for a week or two because we just were uncertain about the data. So, our first convalescent titer paper, which was only a case series of 5, our peer reviewers wanted more information. And so we chose not to rush it out the door. So that took an extra week or 10 days. And then we published 2 papers about potential vertical transmission. This is a huge issue. It was with Zika, it was with other infectious agents. And so our peer reviewers felt like the authors had not yet done sufficient experiments to prove that, or had not done enough biological testing. So we held up those papers, and I think in retrospect, that was the right decision. If it's published this week or a week later almost never makes a difference. And I think that's where we've really lost our way in clinical medicine. The reality is, of the thousands and thousands of papers that have been produced around COVID-19, in the end, there'll be a list of 100 that have really said something new and are really influential. The others help with the picture of COVID-19, but ultimately will not have a substantial impact on either public health policy or clinical treatment.
I mean, I can't remember who one famous editor, Michael Shepard, I think, said, the job of the editor is to separate out the wheat and the chaff and publish the chaff. But you're now convinced, though, you're publishing more wheat.
I hope so.
Yeah. Well, let's go back. David Vassallo, who is an unusual name. I think this must be, again, we get very good people listening in. I think this is the military surgeon from JRMC, actually. I think so. Is asking about preprints. And he's asking really, how safe are they? How valuable are they? And Fee, you are, well, you've already said you're a fan of them, but you did try them before, didn't you? And it wasn't so great then.
Well, we tried them before, and the reason it didn't work is because people didn't send them in. It wasn't like we had a problem. We think it was kind of before the time was ready. But I think this COVID pandemic has shown that we are ready, and I think it's absolutely right. We've got to make sure we have checks and balances and the right a security around them, and also managing people's understanding of what a preprint is and what it can do. But I think the recovery trial is a really good case in point. I would like them to have posted their preprint at the time of their press release. That would have been ideal, instead of which we've just had it posted today on medRxiv. And, it's getting a lot of scrutiny, a lot of comment. People are commenting on the methodology, on the conclusions, quite right too. That would have been nice to have done. I think, Howie's point about why the rush, there is a kind of spurious urgency. You can see why the rush in COVID. I can understand that people are dying and sick and needing, good treatment. But in the end, we want to scrutinize these results, and the press release was really inadequate. So to me, this is an example of how medRxiv really serves the purpose, because we want that paper to be fully peer reviewed. I guess it will be published in a major journal soon. But, this is the way to go, because people understand it hasn't yet been peer reviewed. It can be peer reviewed by the community of academics and clinicians, and then published in a peer reviewed journal when they feel they've done all the necessary checks and balances. Just to be clear, the role the BMJ plays in medRxiv is the oversight of the peer review, the screening. We're very, very cautious about any studies that make claims around things like vaccines or public health interventions of that sort. We have a very very high-level senior editorial scrutiny of every paper that goes up before it goes up. But it's done rapidly within 3 to 4 days of submission. So I think it serves a really important purpose. Peer review itself is flawed in so many ways. There's really great peer review, which I'm sure Howie and I would say happens at our journals and at many other journals, but there's also really poor peer review, and it has a kind of spurious authority. People think it's been peer reviewed, therefore it's the truth. Nobody should ever claim that. And so the current system doesn't work great in all circumstances. I think openness, transparency is the way forward.
I used to go to your peer review conferences
So
JAMA.
you know.
Yes, exactly, yes, and you still haven't got any better. Now, Sudri Chowdhury asked us, what about public peer review of your preprints? Is that possible? Would you favour of it?
Well, in terms of peer review, I mean, people can write comments. I mean, but they use social media to do this. The MedArchive preprints are freely available. Anyone can view them. Anyone can comment on them. In the not too distant future, I hope we'll have a layer of real-time peer review in some way overlaying preprints. And I can see that journals like the BMJ and JAMA, I mean, it's always been my sense that in the long run, journals won't publish original research in the way that they do now, but will act as kind of overlay and interpretation and comment and scrutiny in that way. And that research really needs to be on databases, needs to be on open access databases.
Howie, I get the hint that you're not quite so keen on preprints as fee.
No, I think for the majority of research, preprints are fine. I think they're reported and are often misleading. Some newspapers pick up that there's been no peer review. I think there's certainly been an exaggeration of many of the results that have both in traditional journals as in MedArchive. You know, I read a paper about COVID-19 in children, and then I realized after I actually read the article, it was based upon 50 children. And that was unclear both in the preprint as well as in the news report. So I think sometimes the press hasn't been very clear about where the information is coming from. I think though some of the hype around chloroquine and other drugs has come through the preprint servers. So I do think people need to understand there's a balance. The pandemic is unique. We publish about 100 clinical trials a year. And 50 of them, I would say about half, the conclusion changes after it goes through peer review. You know, an exploratory outcome that was reported as the primary outcome, or a misunderstanding of the absolute differences. And so I do think around clinical investigation, particularly clinical trials and meta-analyses that really influence care, I think I'm more hesitant about the value of preprint servers.
If I can just say, I mean, my understanding is the hydroxychloroquine hype began with that French study that was published in a journal. I mean, it did appear on the same day on MedArchive, but it was published in journals. So my point is that journals hype stuff, and I don't think necessarily that the preprints will do more than that if properly presented and properly reported.
All right, but come on now, you two. I mean, the chloroquine hype began when President Trump mentioned it, and we often say it's a pity that our leaders don't have science or medical backgrounds. So how you must have been pleased when your president seemed to think that he had.
I think people know I've done quite a few live streams with Tony Fauci.
Yes.
Tony may be the only public figure in medicine who leaves with his reputation intact at the end of the first wave. Tony, in his inimitable style, had found a way to disagree with the president and remain in his position. Yeah, we've really struggled. There was an interesting article that compared President Trump to President Obama. When there was a flu epidemic, the CDC gave 100+ press conferences. President Obama spoke about it 3 times. In COVID-19, we've had many politicians, not just President Trump, become the medical experts. And I think that's a mistake. I think public health folks really are much more effective at communicating information. We somehow have allowed masking to become a political football. in the United States. And I think if the conversations had been led by public health experts, physicians and non-physicians who really understand what masking was meant to accomplish, I think it wouldn't have been a political football. And that is not just President Trump. There's been many other politicians who wanted to have daily and weekly press conferences.
And people should read your interview with Anthony Fauci. It is very good and very new. Fiona, I mean, talking about relations with government, though, in the last epidemic we had, pandemic, you made a nuisance of yourself by attacking the government's policy to stockpile Tamiflu, spending billions of pounds on it, publishing papers saying it didn't work. What are you going to attack the government for during this pandemic?
Well, I mean, Simon, I wouldn't like you to think that we see it as our role to attack the government. But I think the truth is we do probably, we're there as a kind of additional accountability mechanism for any government in power. So we pretty much do, regardless of flavour, attack governments on their, or not attack, but, hopefully constructively criticise. I think that the difficulty with this situation, with the UK government's handling of the pandemic, that it's been very hard to find anything to be positive about. It's been a series of really pretty shambolic decisions and communications. We've had the PPE failure to provide. We've had the lack of preparedness generally. We've had the talk about the NHS not being overwhelmed, but only because it stopped doing absolutely everything else. And the NHS has responded magnificently, I think, given the lack of resilience that was the result of 10 or more years of austerity. The public health system has been stripped away over that same period. So this government inherited from their Tory predecessors a stripped public health system, that fragmented, centralised, without the local infrastructure. And so in addition to the PPE procurement problem, we've had the shambolic testing with no strategy, numerical targets being chased rather than actual clinical or public health need being met. I mean, it just goes from one shambolic situation to another. And the results, sadly, are clear in our very high COVID-related and directly and indirect COVID mortality, which, is a shameful position for the UK to be in. We've spent our time as a country going around the world telling people how to do public health based on a very strong tradition of communicable disease control. And I just think it's really, really sad. The question now is whether we can pull ourselves up. What's the plan for the rest of the year? Are we prepared for a flare-up or second wave? What needs to happen in order for us to be prepared? Are we protecting the vulnerable? All of those issues. And just today, we are sending an open letter to all leaders of all UK political parties. When I say we, me, Richard Horton of the Lancet, all of the major medical rail colleges and the BMA, to ask for a rapid review, forward-looking, what needs to be done to ensure UK preparedness for a second wave.
I want to say one thing. I think medicine owns some of this. It's always easy to blame others.
Yes.
So let's talk about looking inward a bit. The data about asymptomatic spread was available in late January or early February. And we didn't crystallize the need to mask in the United States for many weeks after that. And we didn't, and there was not consistent public health messages about social distancing. And I think we own some of that. I agree with everything that Fee said about testing and our leadership in the United States. I mean, the CDC and the FDA struggles, but I also think we as journals and public health folks really didn't speak with a very, very clear voice about masking and social distancing. And we own that.
I think that's quite right. I was, in fact, just about to put to you what Dorothy Byrne, the head of news for Channel 4 over here, said. She gave an interview, she's a journalist, obviously, on mistakes that journalists have made. And one thing she said was, and this may not quite resonate in America, but it resonates a little bit in the UK. She said, to be honest, I don't think it was taken seriously until Lombardy, the north of Italy, everybody's favorite middle-class destination, went into meltdown. So she was saying that the news media in general were slow on the uptake. And I think that's the point you're making, that we also need to look at ourselves. And was the BMJ slow? I mean, Richard, who you almost became but didn't, does say that Lancet published very early on. but nothing was done about it. What's the BMJ's track record on that?
Well, first of all, to say I think the Lancet's 5 papers in January were very important and good, and I think Richard's right. Although it's always a bit difficult when one says to the journal editor, we wrote this and people ignored us. I mean, the answer is that's sort of slightly implying we have a more important role than we do. But I think he's right to say those articles were important. They came directly through from China, and they should have been acted upon earlier. I think the BMJ did pretty well. We published stuff from January. We published continuously right on from there. We've done our best to cover the UK while also covering the international scene. I mean, I take the point about the need for people to stand up and be counted, medical journal editors and public health leaders. I think the UK situation is slightly different because of the government control of public health in ways that may be rather different in the US, and the funding for that, and the way in which the government, through the Health and Social Care Act, centralised into Public Health England, which I'm afraid has proved itself not fit for purpose, and while removing resource from where traditionally it has been. So that's a slightly different setup, and I think we have been shouting about that from the pretty early on in the pandemic, to say local, local, local. You need to invest in the NHS local provision and not go down the commercial route, which this government seems to be bent on doing.
Okay, well, we need to come to an end. It may be that whilst we've been speaking, Boris Johnson has been announcing a whole series of changes, just as you have requested, but we will find out when we finish. We do need to finish. Don't go, you two, but first of all, thank you so much for doing this. And I know just how stressed and pressured you are, and also how well both your journals have responded. There have been a lot of questions suddenly turning up, including one just from Richard Horton, but we haven't got time to take that. But what we do is next week, this Tuesday next week, at the end of the month, we will round up on all the questions that we didn't get through during the series, and there will be hundreds, but we will select some better ones. I imagine Richard's will be one of them. With Peter Oppenshaw, Nick Patel, and Debbie Sridhar. So there will be a roundup this time next Tuesday. In the meantime, on Thursday, our second webinar of the week, Beverly Hunt from St. Thomas's, who's very well known to many of you, will be there to talk about thrombotic I put combinations here because of my typing, but we mean complications of the COVID epidemic. So that will definitely be one to tune into. And after that, on Friday, I would just like to draw attention to the LGBTQ healthcare webinar that we will be running for RSM. We did this last year. It was wildly successful. And I do invite you all to join that. And then finally, for a bit of relaxation, tomorrow we have our long interview, and this one at 7 p.m. tomorrow. Vicky Hayward of the RSC and National Theatre will be in conversation with Susie Walton, and hopefully Vicky will have had some good news on the future of theatre in this country, or maybe not. We shall see when we end the webinar. So may I again thank Howie, and may I thank Fee for coming on today and taking up your time. It's been great. There's huge areas to touch at, so I'm sure we'll probably come back to this topic actually, because actually there's a lot more interest than actually I was predicting, which is wonderful. And in the meantime, can I just say to everyone, as ever, the words of Hill Street Blues, please stay careful out there, and we shall see you next time. Good afternoon.
Thanks, everybody. Stay healthy, Simon.
Thanks. Bye.
Thank you.